So welcome to week 5. I do hope that you did get that interactive PowerPoint. We're able to look at it because this is a rough week. Cardiac, some of it is similar to med-surg, but some of it is not because they're congenital heart defects. That means these babies are born with cardiac defects. Some of them require immediate intervention to get oxygen around in their body, and some of them can wait to be repaired. So as I go through it, again, you don't understand, please stop. I do try to make it as simple as thinking about a kinked garden hose. If you kink a hose, where does all of that water pressure go? It goes backwards. So if we know how to trace a drop of blood, then we can figure out where is that blood going to pool and what symptoms I'm going to see. Okay, so just remember that as a hint. You do have quiz 3. It is on cardiac, it is on respiratory. I will cover it in class today to be sure that you understand it. If it's not on the PowerPoint, it's definitely on the Kahoots. And I think you can see how those Kahoots really give you those concepts that you really have to understand. You know, you're going to see them again in a different way, shape, or form. You also have a discussion question this week, and it's about an asthmatic child. And it's going to make you understand about respiratory distress in children. So that is what is due this week. Again, remember, start preparing yourself. What are you going to use for your week 8 pediatric assessment assignment? You can make your own child up. You don't have to have one that you know, okay? But remember that the assessment must fit what the diagnosis is that you're choosing. If you choose asthma, those lung sounds better reflect those wheezing, that expiratory wheezing and nasal flaring or retraction or, you know, coughing, okay? So just make sure that it does reflect that. And do not put down on there normal limits, you know, heart normal limits. Well, what are the normal limits, okay? So let's start out with the PowerPoint, and then we're going to go to the Kahoots. Does anybody have any questions about last week? You know, I did do it through a Kahoots, but remember that chapter 39 is pretty rough, and you should go through it, especially reading those little boxes in that chapter, because there's some key information there. You know, I try to cover it all, but, you know, it's impossible to cover absolutely everything, okay? How was the exam last week? Is everybody okay with it? I think that some of the questions that you got wrong were on Erickson's. Infants, remember, is, you know, it's not that they know they're going to be fed. It's just that they know that their needs will be met, you know, somehow, okay? Not that they know mom and dad and that. So Erickson is one that you should look at. And then dental. It was talking about first graders and a nurse teaching. We're going to teach them how to brush their teeth because at first grade, age 6, 7, they don't have that manual dexterity yet to floss. So those were 2 of the questions that I saw a lot missed, okay? So let's go ahead. Let's share. Let's go to our PowerPoint. Remember, stop me if you're not understanding, because I will answer whatever question you have. You know, you have to thank my daughter for that. My daughter probably asks 50 questions every single day. Every day she has 50 questions for me, and I always answered them. And my daughter to this day thanks me because I never told her to shut up. I says, okay, what do you need to know? And explain it in a manner that she understands. So she prepped me for you guys. And she's 37. So she's right around some of your ages and sometimes a little bit older. Okay, and that's my little baby. I'm getting too old for this. No, I'm not. Respiratory infections. Well, when we think of the lungs, we think of upper respiratory and lower respiratory. When it's upper respiratory, it has to do with all the mucus in the airway, sinusitis. And then the lower, you're thinking the bronchioles, alveolar. We're thinking more of asthma or pneumonias, right? So most upper respiratory illnesses are viruses. Most of them are viruses. If we have someone who with a pneumonia, we usually will treat them because of the consolidation. We know there has to be bacteria there. We will treat them with antibiotics. but sometimes they could even be a mix of both. And there's all different types. It could be the strep, Haemophilus influenza. It's actually a really horrible pneumonia. It takes a lot to treat it. And of course, mycoplasma. Now, what do we need to know about now getting into infections in children and how we need to treat them and how we should react? Well, we know babies are born with only mom's immune system. We know that they start to build up their own immune system somewhere between 2 to 4 months. They're starting to accept things. That's why we give those immunizations 2, 4, 6 months. Those are the big, horrible diseases. We want to protect them. So we know less than 3 months, it's mom stuff that's really working the most, but then it starts to go away. It starts to die off, which is normal, like blood cells, they start to die off. We know that the infection antibodies they give us start to die off. Now they've got to make their own. So you will see children ages 3 to 6 months start to get sick. Hopefully under 3 months, they don't get sick, because if they do, we treat them very seriously and we do complete septic workups on those children, usually including a spinal tap. As we get older, toddler preschoolers, well, how do they explore the world? In their mouth, right? Sensor and motor. So what are they doing? As I've always said, swapping spit between each other. One toy to another toy, a crayon, a pencil, in the mouth, in the mouth. And of course, there's going to be a really high viral rate of infections, upper respiratories and coughs for sure. Now they're starting to build up their immune system. They're getting ready to go to school, swapping all of this, viruses all over between them. After 5 years, it gets to be more of your bacterial, because your viral system, immune system's getting better. We know as you get older, I get older, children get older, you're going to come in contact with these viruses and your body is going to build up immunity. So as you get older, you will be sick less because your immune system's better. Now, one of the things about children and their ears, we know that there is really small, short, wide open tubes. You get mucus in the nose, it's going to go right into the ears if we don't get rid of that mucus. It's like, all of this buildup, where's it going to go? It's going to find a place. And that is shooting right up into the ears. And we know ear infections hurt. So pain control is huge. And of course, this will have antibiotics. Usually it's a staph infection. That's why we're going to use, usually, first of all, amoxicillin. What does a kid look like when they're sick? So you might have a kid who not complaining of an ear pain yet, not really complaining of a sore throat, not quite yet, maybe a little cough. But when you see a child all of a sudden stop eating and then not playing well, look, probably you're going to check that child's going to have a fever. And it could be nothing fever in the morning, and this is in the afternoon. So you start to see a fever, they stop eating, they might vomit once, they might have a little diarrhea, or their tummy hurts. You might see a cough, sore throat, or you might see that nasal mucus. And you might feel those rhonchi and, hear those respiratory different, sounds that are in there. But a kid who's not eating and is sitting and trying to sleep when they shouldn't, those are your two things. Check your fever. So what is our goal in respiratory care? Well, we want them to breathe easier. They'll breathe easier. They're going to be able to rest and be comfortable. Medicating them for that fever is going to bring the fever down, and they're going to be comfortable, and they're going to be able to eat better, drink better, sleep better. And this is better for the child because rest and fluids is one of the big things with it. So preventing spread of infections, covering the mouth, using tissues, putting them in the garbage cans, etc. And then, of course, mommy being there and maybe giving them that special ice pop or that special fruit juice they don't normally drink, and, making them feel better. As I said, ear infections, what do we see? Well, you're going to see the middle ear, and you're going to see like the eardrum's going to start to be bulging. And I'm telling you, some kids are holding their head. Sometimes the younger kids are just banging their head, banging their ear, and we can tell it's an ear infection just by the way that they're looking. Some of the kids can't say it hurts yet, but they can be pounding, against something. We know it's probably that. So as I said, we treat it with number one, give them something for pain. And you know, Motrin has a little anti-inflammatory in it. That's why I always recommend number one is Motrin for ear pains. For you of those have small children at home, it works better than Tylenol because of that anti-inflammatory, and it does bring down that fever also. Of course, we're going to give antibiotics, make sure they take all the doses of it. You know, that after 3 days, and it's such a hard thing to get that kid in the antibiotics, and they stop giving it. And then, of course, they're going to have a reoccurrence. Reoccurrence of ear infections can cause hearing loss. So we don't want that. So we want to make sure they get it done. Now, I know that actually myself a couple of years ago, I had to have tubes put in. And I know that one of my two grandsons, the older ones, both of them had to have tubes put in their ears because of chronic ear infections. And this was a mother who's OCD about making sure every drop of antibiotic went in. So even if you're perfect, it's still going to happen. So nursing care, pain management, okay? And also telling them about the antibiotics. Now, infectious mononucleosis, mono, we think of that, we think of the kissing disease, right? Usually we think of teenagers kissing each other, they can give each other mono. Well, let me tell you a story about mono so that you can understand it a little bit better. It is a herpes-like Epstein-Barr virus, so it is a virus, okay? So no antibiotics are needed. These children will come in with complaining of fever, being really tired, and a sore throat. And then, of course, those feverish things, body aches, pains, and of course, lymph nodes will be also swollen because they do have this viral infection. So they go into the doctor, they do a strep test, they might even do a flu or a COVID test, everything's negative. They go back after 3 days because he's still with fever, still feels terrible, still fatigued. And they might say, well, we don't know, but let's just put him on antibiotics. And that does happen. And then after another couple of days, usually they'll show up at urgent care or even the ER, and they're going to say, well, we went, this is all negative. Then they put them on antibiotics, and no, that's not helping. What's going on? Well, when we hear these symptoms, we're going to say, let's do a CBC. We want to look at the white count, right? Is there an elevated white count, something we're missing? And we're going to do a monospot test, which is a blood test. And that monospot test usually will come back positive. So nursing care. Nursing, what do we need to teach these parents and the child too? Well, they need to protect their abdomen because their spleen and liver can become enlarged. The spleen could be like a big balloon. And sometimes if it's punched or they fall, it can explode and it can cause them to die. Okay, a little boy came into the ER with me, 9 years old, and this is a true story, guys. Came in with his father and complaining of everything I just said. Still sore throat, feeling bad, still fever. We did the labs, monospot was positive. Now, I was with a really good physician that day. He explained it to the father and to the child. And then, of course, I also re-emphasized no PE for the next couple of weeks till you're seen by your primary physician. Also, make sure no rough housing with brothers and sisters at home, protect that abdomen at least 2 to 3 weeks, again, until seen by that pediatrician. Sent them home, they understood, signed the papers. 1 week later, I am the primary trauma nurse on duty, which means any trauma that comes in, I'm the one who runs it, I'm the one who documents it, I make sure everything's being done the way it should. We get a call. There was a 9-year-old boy on a 3-wheeler in the Everglades, fell off and fell on a rock on his abdomen. He was airlifted in and he was pronounced dead on arrival. This was my infectious mononucleosis kid. And I saw the kid. Now I'm primary, I remember. Don't ask me where my car keys are, but any child I've ever taken care of, I look at them, I will remember them and who they are. This child died because this parent and him said, well, 3-wheeling was more important than protecting his belly. And they didn't understand the ramifications, even though I made it very, very clear. So mononucleosis, nursing care, protect the abdomen from injury. Tylenol and Motrin for fever and for pain, plenty of fluids and rest. That's the treatment. Croup. Ever hear a bark that you can hear that sounds like a seal, right? It is a loud bark. It's inspiratory stridor and this barking cough. Now, croup itself is, again, is another viral thing, and we treat it with a dose of steroids or a couple doses of steroids. Sometimes it has a little fever, sometimes it doesn't, but we don't want that croup to continue without treatment at all, because it will turn into epiglottitis. Now, epiglottis is what? It's that leaf-like structure in the back of your throat that covers your trachea when you swallow, so you don't inhale your food into your lungs, right? So when that epiglottis becomes swollen, air can't get into the lungs. It becomes an emergency. So these children, if you can imagine the airways covered, it's like putting a hand over your airway. These children might have a little piece of air that can get through it. They're leaning forward. They can't swallow, they're drooling. They can, like that is the way they'll be talking. So we know something's going on in the back of their throat. So they're not swallowing, they're drooling, they're complaining, their throat hurts, and they're usually bent over, almost like that tripod COPD med-surg position, okay? How do we treat this child? Well, this child, because of the chances of that epiglottis completely closing and having no airway, you need an intubation tray and a tracheostomy tray at the bedside. Usually these children are brought into the trauma room where all of this equipment is available. So what do we do? Well, there's swelling in there, right? So nothing by mouth. They can't even breathe. They can't swallow. Nothing to take by mouth. Get an IV in, IV steroids, and they're going to be giving a racemic epi aerosol to try to get it right to the area to decrease that swelling. Acute laryngotracheobronchitis is basically your croup. Now, it's another name for it. Again, this is a virus. Again, it needs steroids for the treatment. So this croup, usually you have a little cold, a little remnants left over. You'll see there'll be some swelling in the back of the throat because of these coughing, but you're going to hear that inspiratory, not expiratory like asthma, inspiratory stridor, and you're going to see some retractions. And I'm telling you, you can hear the barking cough from across, a whole big room. You'll say, oh, that's croup. Again, remember, if we don't treat it, it can run into epiglottitis, and that could run into respiratory acidosis, and you're going to stop breathing because you can't get air through. So what do we do for these conditions? There's swelling in the throat. There's coughing, barking, which is letting you hear it. Or with epiglottitis, they're drooling and garbled voices, and something's happening. So number one, you have to maintain hydration. Some simple croup kids can still eat oral, eat or drink orally, but as they get more severe, it's only IV. If we put a little bit of supplemental O2, all that O2 does, it just relieves the hypoxemia, right? Because if they're not breathing well, we just want to relieve that hypoxemia. And again, that nebulized treatment, that racemic epi goes right back there to decrease the swelling, just like epi does if you're given a sub-Q injection. And of course, steroids, again, decreasing inflammation. Now, this is an interesting story. Again, RSV, respiratory syncytial is also known as bronchiolitis. For you and me, it's a common cold. For a very young baby, it can be a lot of problems. Well, babies are obligatory nose breathers, What does that mean? That means they only breathe through their nose, even though they have a mouth. They just don't know how to do it yet. So if they're eating, drinking a bottle, sucking a breast, and breathing, it's difficult because their nose is all clogged up full of mucus. RSV is a lot of nasal mucus, which causes, a lot of respiratory complications. And then of course it stops them from eating. Now, usually RSV, it is a virus, so no antibiotics. Usually we'll tell them to suction the nose out before they eat. If they have a little fever, Tylenol for the younger kids. After 6 months, you can add Motrin to that. And then, give them rest periods as they're eating because their nose is clogged up and they will tire out. Now, what if you have a cardiac condition? Or what if you're diagnosed with cystic fibrosis or some other autoimmune thing that makes this one more thing that could put them over the edge and really harm them? Well, we need to prevent them from getting it, right? So there is a vaccine called Synagist. It is a monthly vaccine given once a month for the first year of life, usually between, early fall to late fall to early spring. So fall to spring. So it's like 8 months there that we do give it. And it prevents these children from getting this nose full up and fever, which could cause other problems to that cardiac or that respiratory compromised or immunocompromised child. So nursing care is making sure we clean that nose out, feed them slowly, and then of course monitor them for respiratory distress. Most of these children are not admitted, they go home unless they're really retracting and are already dehydrated because they haven't eaten, if the parents waited too long to get them in. My stepdaughter had a baby last Monday. Her son, who's 2.5, grandma brought him to the doctor because he had a fever and a little rash. And the doctor said, he has RSV. So they're calling me like crazy. What do I do? The baby's coming home today. He has RSV. And I'm like, well, you are going to isolate that baby and you are going to wear masks and you're going to wash your hands. And the baby did fine. And of course, the little boy, he's 2.5, is fine already. So that's my RSV story. That's a very recent one. Pneumonias can be caused by different things. Could be bacterial, or it could be something you inhaled. We used to put beautiful Johnson & Johnson baby powder on little babies because it smells so good. Well, we found out that talcum in the air goes in their lungs and could cause a lot of problems. So we don't use that anymore. And I remember when we stopped using it, I was sad because I loved the smell of that stuff, but I understood why. So pneumonias, what do we do? Pneumonias usually come into the physicians with they're vomiting, they have a fever, and they're not eating, and they might have a cough. And we listen to the chest, and whatever lobe has that pneumonia in, it will be decreased. Usually their fever is between 101 and 102. That's my personal thing I've seen. 101 to 102 with those symptoms, I can almost guess it's going to be pneumonia. How do we treat it? Well, we treat it with antibiotics and also drinking plenty of fluids. And of course, if they need any sort of saline aerosol stuff to loosen it, help with that cough, because we want them to cough. We're not going to suppress a cough. We want that stuff to come out. So something to help the mucus come. As I said, pneumonias could be viral, but we mostly will treat them for bacterial. And today we do have that pneumococcal vaccine, which is great because pneumococcal pneumonia is actually one of those more severe diagnoses we don't want them to have. Pertussis was wiped out completely, whooping cough. When I was young, they gave us all of these things, and we give these immunizations, but there are some children who do not get immunized. And because of that, they put other children at risk for that exposure. Highly, highly, highly contagious. It is a respiratory sort of isolation that's required. It's droplets because they're breathing and they're coughing everywhere. Yes, there is a vaccine for it, but again, young kids have a hard time with it. So we give zithromycin for this child. And if they're admitted, it'll be in one of those rooms where it's called reverse flow, where we don't let the air from that room go into the hospital. It goes directly outside. There, usually every unit has one of those rooms. Foreign body aspirations. Well, a child can literally get anything aspirate and cause them choking. It could be beads, paper clips. I mean, the most of all are these coins. And it's not the dime or the penny, it's the quarter. I've not seen actually many pennies or dimes. It usually is the bigger one. And if you look at that x-ray, that's usually where it gets stuck. So how do we get that out? Well, years ago, we bring them up to the OR, put them asleep, put a little scope down, little clips, and pull it out. But we found that if we take today, put the child in, and it's usually in the surgeon's lap with mom and dad right there holding the child's hand, we put a Foley catheter down the throat, blow up the balloon, lean them forward and pull it, and the coin will pop out. So before we do that, I'm going to tell the kid, they're going to put something in your throat. It doesn't going to feel good, but when the doctor pulls it out, the coin's coming. And if I get it first, it's mine. So now their mindset is on, I want to get that quarter. She's not going to get it from me. So I've distracted this child, haven't I? So nursing care, before, during, after, you always worry about the respiratory. Are they breathing? You know, their function, are they good? You know, and any aspiration, we are going to do an x-ray to see what it is and where it is and the treatment. But the first time I saw that Foley catheter, I thought it was the neatest thing. And they'll like vomit some mucus and spit up. And usually it's one attempt and they get it up. Again, that aspiration pneumonia, not only is it powders, you know, some people like to go into the bathroom and use bleach and comment and this one and that one together, and it's quite caustic. I mean, have you ever had, you know, like a bronchitis because of what chemicals you used in the bathroom? Well, these children should be kept away from it because it does, it irritates, it burns their lungs. Another sort of aspiration is children with reflux. You know, adults get reflux, so do children. And why do they have reflux? Well, are they burped properly? Should they sit up afterwards? Were they overfed? So all of these things are stuff that we need to teach our parents about how to feed their child, making sure they're burped, showing them all of those positions. I call it the rock and roll method. I move them up and down. I mean, you get up from a table sometimes and just the change in position, you burp. Well, I move that baby up and down and I roll them around, of course, holding their head as I go, and you'll see them burp and, you know, making sure that's up. And it does decrease the amount of aspiration. The other thing we do on those children who just continue, the first thing we're going to do is take that formula, even breast milk, we'll take a little bit and we'll put it in some rice cereal. Now, rice cereal has no nutritional benefit. All it does is it thickens the milk to hold it down. And we put like 1 teaspoon in 30 mLs. So in 2 ounces, 1 teaspoon. And it does, it helps keep that formula down. Another thing that can happen to children is what we call acute respiratory distress syndrome, ARDS. And this is a child who's had some sort of injury to their lungs. We can see it if they're overwhelming sick with infection, sepsis, or if they have been hit in the chest, car accident, something of the sort, ran into by a car. As you get older, the teenagers' drug overdoses can cause it. And then, you know, I live in South Florida, so near drownings. And what happens is you do not see the insult immediately, especially if you're talking about drowning. You're not going to see them having respiratory distress. Sometimes you pull them out of the pool or the ocean and they cough and sputter and they're awake and they're running around. And you're like, oh, the kid's fine. And rescue's there and they're going, we're taking him. And you're like, no, he's fine. And they're going, no, we need to take him for evaluation. It's because it's up to 72 hours later, you can see the signs of respiratory distress. So in the hospital, they're usually in a step down area at minimum, and they're going to be watching their oxygen saturations. These children are sick and they're very, very high mortality rate. So if we can get these kids over their first 3-4 days, they'll be better. I mean, this is a picture of a child on ECMO, you know, where the lungs were so damaged, we had to breathe for them. And depending on how long they're on this ECMO, depends on how long they're going to, you know, if we can get them off quick, their outcomes are better. They stay on too long, you know, those outcomes are not going to be as good. I used to run these ECMO machines when I was working up in the NICU and PDICU, and it's quite an interesting thing to watch these children go through it. Now, CPR, you've all been taught CPR, right? Well, what about the parents? Did we ever think about parents in a hospital? Well, it used to be we kicked all parents out. And now this parent is there, my poor child needs me, and nobody's holding his hand. Nobody's stroking his head. All they're doing is doing all these things, and oh my goodness. And it's a very difficult thing for a parent. So if at possible, let them stay there. Now, if your hospital policy absolutely permits you not to do that, have somebody stay with that parent and give them continuous updates what's going on. And when they are done, make sure that doctor comes and talks to those parents about the outcomes and what's the prognosis. I mean, what happens if you're in the hospital and you're a nurse and a child, you find them, you walk in the cafeteria and there they are on the floor unconscious. They're not breathing. What do you do first? Unconscious child, unwitnessed. What do? You start chest compressions. Then you do 5 rounds of chest compressions or 3 rounds, whatever the protocol is, and then you call for help. But it's not necessary to do breaths at first anymore. It used to be years ago when I started CPR. They feel there's enough oxygen left in the body. And many people were not given CPR because of today and germs, etc. So they didn't want to breathe and do mouth to mouth. They're saying as long as you start CPR, you know, chest compressions, that child, that adult has better outcomes. So unwitnessed, unconscious child, number 1, start chest compressions. So asthma, probably the most common of all childhood illnesses. Many children have various degrees of it. And what it is just your lungs have this hyper responsiveness and they get swollen due to usually some sort of allergen. It could be food, it could be pollen, cats, dogs, dust, bed mites, it could be so many things, you know. So how do we treat asthma? Well, number 1, we need to look at the function of the lungs and we need to find out what are they allergic to, because if we can eliminate an allergen or desensitize them, they're going to have less asthmatic attacks. So in asthma, we are going to be given what? Well, rescue. Albuterol inhaler, Proventil, whatever you want to call it. One of the things with children is get a younger child. Can they take it, hold it, put it in their mouth, put their lips around it, and inhale as they take a deep breath in? Usually not. If you see this orange, pink, and blue things, they are called spacers. And you put in that meter dose inhaler thing on the back of it. There's a hole. You push, let's say it's 2 puffs, and let them breathe in and out 4 or 5 times. Most younger children cry when you do that, but you know something? They're taking deep breaths in, aren't they? So actually they're getting the medicine good, so it's okay. Now, if you are considered asthmatic, they will be putting these children on some sort of preventative medicine. You know, you look at adults, you see Symbicort, Advair, Brio, right? In children, levoalbuterol, and we're talking Pulmicort, which is A little bit of steroid in the aerosol given twice a day. It prevents asthma exacerbations. It's not for when you have an acute attack. That's when you use your rescue thing, okay? And of course, they like now to give to children 2 and older that Singular, which does help. It's like a Claritin, but it's more specific to the lungs. So the long-term medicines, as I said, is those morning and night things, usually Pulmicart in little children. They do have other little inhalers sometimes they use. Of course, they also, as if you're having an asthma attack and you can't control it with just the, the rescue and the other medications, they will put this child on steroids. And what does the steroids do? Well, asthma is a swelling of the bronchioles, and it causes rubbing and irritation, which causes the cough. So we decrease the swelling with steroids. Okay, that is respiratory. By far, there's other stuff in respiratory. I'm going to cover some of it in the cahoots because it's hard to get it all in there. Now, cardiac dysfunction. Children can be born with a heart disease, and it could be an opening not there. It could be the switching of the pipes in the wrong way. It could be a muscle not working, could be a kink in the aorta, so many things that could happen. And as nurses, we're going to be looking for these things, because usually after the physician gets the baby, does a quick something, they give them to the nurse and we do our assessment. I have found coarctation on one of the newborns when I was just starting in the pediatric world. So I was pretty cool that I saw that, and I barely understood what it was at that time. And we know it can be acquired. Viral cardiomyopathy could be due to viruses, right? Autoimmune, well, think about lupus. What does lupus do? It attacks organs, right? Or it could be environmental, it could be, one of those plants blew up and all of these chemicals out there. It also could be families. Now, I'm going to discuss the first type of defect. The first thing you need to know is how blood flows. It goes from the vena cava, inferior, superior, into the right atrium. Goes through the tricuspid valve, the right ventricle, pulmonary valve, into the lungs. Back through the pulmonary veins, into the left atrium, through the mitral valve, into the left ventricle, out the aortic valve, into the aorta, down the arch, into the body. Okay? Now, if you look at the red curve of the aorta coming around, what happens if after those 3 little things that go to the upper body, there's a kink, a narrowing? The blood can't go through there. Think about how much that left ventricle is squirting and pushing against it to try, right? So what are you going to see? Well, blood can't get to the lower extremities. It's kinked. It's a narrowing. It's called a coarctation of the aorta. What are those physical assessments? Well, you're going to see no pulses in the lower extremities or extremely minimal. When you see that, what should you do next? Well, if I'm not seeing pulses, I want to make sure they're going everywhere. I'm going to do a 4-extremity blood pressure. Now, because all of that blood can't go down, it's kink in the hose. Got to go somewhere. Well, some of them go up the subclavian and up into the head, right? Also, it's going to go to the upper body, the arms. The upper extremity blood pressures are 20 millimeters of mercury higher than the lower. Blood can't get the low part, so it's lower, and it's going to be higher in the upper extremities. Now, the one thing about a coarctation, you always don't see it at birth. Sometimes the kid's a couple years old where we're starting to see symptoms. What would we see? Well, there's extra blood going to the upper extremities, nosebleeds, headaches, These are two things that would make a physician go in and say, let's do an echocardiogram. Let's look at this child. Okay, following me? So you get a child, comes into your doctor's office, and they're giving you this history. They're not eating good. They are tachypnic, tachycardic. They're not gaining weight, which we know is serious cognitive delays, right? So they have no tolerance for activity at all. And of course, then you're going to see those delays. Infants, you're going to see nasal flaring, and you might even hear them grunt. And it's not like you think. It's like they take a breath out and they go, eh, eh, eh. It's very subtle. You'll see the retractions, supraclavicular, intercostal. You'll see that nasal flaring, and then that you hear on an infant. That child is very close to the respiratory system for stopping, okay? So what do? I mean, the heart's not pumping good. The blood's not getting where it should. They're not getting that oxygen around in the body. So we need to do something. So again, we're going to be continuing our inspection. I mean, if we see a blue child, it's going to be easy. But when we see those type of respiratory issues, or we see no pulses, lower extremities, we're going to know more. As they get older, you're going to see things like clubbing of the fingers. That would be some of your cyanotic heart defects. But you're not going to see that yet with an infant. Another thing we're going to look at is sometimes you can feel murmurs in the chest just by putting your hand on an infant. I mean, their heart is right there. You can feel it, or their abdomen, really abdominal breathing. Feeling the pulses, as I said, you'll feel upper extremities, maybe not lower. And then what's the heart rate? Well, a heart rate of 184 on an infant at sleep is too high. What does that mean? Well, it means that the heart's not beating the way it should. It's trying harder. So it's beating faster to try to get the oxygen around. And guess what's going to happen? That heart's going to tire out, isn't it? And of course, we're going to listen to see if there are murmurs. So how are we going to evaluate it? Well, the first thing we do is an EKG, just like we do with adults. Well, then we're going to do your echocardiogram. And that echocardiogram is going to show blood flow going around in the heart. And if we see anything going on, prepare that family, because they are going to go for a cardiac catheterization. What does a cardiac catheterization show the medical team? Well, once you think you see something flow's not right, you can find out exactly what's going on. And many times cardiac caths, they can do something to fix it, or sometimes it's just to get them prepared for surgery. Now, a diagnostic is that, finding out what's going on. So what's the difference between diagnostic and interventional? Well, some children get older and they have what we call these tachydysrhythmias, which means the heart rate goes up and down by itself. That means there is something in that right atrium that's not the SA node or that pacemaker of the heart. It's a different place in there saying, I'm going to beat for a while. The normal heart rate of an atrium that's not the SA node could be 240 beats a minute. So you could see you can have an elevated heart rate because that other place says, I'm going to beat for a while, nanny, right? Interventional cardiac cath, what does it do? It goes in there and zaps that piece, that little muscle area in that right atrium that's trying to take over the heart, and it stops it. And that's also called those electrophysiology studies. So it says heart, no, you can't do that. Sorry, the SA node needs to be my pacemaker and you can't do it, but thank you anyway. So as nurses, how are we going to prepare these children? Well, before they go, they basically just need to be NPO up to, a breastfed baby 2 hours prior to procedure, formula 4 hours prior to procedure. And many of these children are eating. It's just that they need to get a cardiac cath. Now, The thing about coming out of cardiac cath, let me explain how they do a cardiac catheterization. They put 2 catheters in the right femoral artery and right femoral vein. That means that right groin is going to have an area with 2 punctures. And those type of catheters, they're actually pretty large, okay? After they're done with the procedure, they pull them out slowly, they put pressure on them till they stop bleeding. And then they put a pressure dressing on it. But putting them back on the bed or on the warmer to bring and roll and bump on the way back to the room, you could have dislodged that clot. You might, and the first thing you need to do is check that dressing before anything else. Can you imagine these big holes squirting blood out on an infant, a newborn? It's going to lose a lot of blood really quick and be really dangerous. I mean, an ounce of blood for me and you is nothing. On an infant, it becomes something, okay? So open up the sheets, look at that dressing. What if you see blood on that dressing? You're going to put 2 fingers right above that. Means right at the groin, but not on the holes, closer to the heart a little bit. If your hole is right here, it's right above it, and you push it down, because that's the way blood goes, down to there. And you're going to hold it, and you're going to, of course, ask for help if there's a physician there. And they're just going to be there to monitor and look how much blood was spilled, et cetera, and look at vital signs. Okay, now you've got that bleeding stopped. There's a pressure dressing on it, and we're good. Now we're going to take vital signs. Now, these children can eat and drink normal, but you can see how it is to keep that clot really good on that groin. It doesn't matter. Newborn's extremely dangerous, but it's really dangerous for older children too. And older children do get cardiac caths. Adults get cardiac caths. No out of bed for 24 hours. They cannot get out of bed, no ambulating. You cannot bend that leg. You have to keep it straight. And older children will have a sandbag on there to hold that dressing, because that's how important. So IV fluids or PO fluids, whatever, that's fine. Slowly, you can elevate the head of that bed a little bit for eating. And we do check blood glucose levels. We don't know what fluid was given in the cardiac cath lab. Did they get sugar? Do they need it? You know, so it is something we monitor when they arrive from the cardiac cath. Now, when I first started in congenital heart, you know, working in the cardiac intensive care unit at Nicholas Children's, I didn't realize how many children had congenital heart disease. But, you know, I got to realize there are quite a few. And, you know, our job as nurses and medical professionals is tried to do and come up with new procedures that can save more lives. It used to be some of the really bad cyanotic diseases, over 50% died. Well, today, after those 3-stage surgeries, 95% are living. So there is so many changes that have gone on. Now, one condition that you can probably think most of the time that's going to have a congenital heart defect is those children with trisomy 12, 21, 13, 18. There's also 15 and 11 and 9. Actually, I saw 1 9, really severely deformed heart that child had. But your Down's children are more susceptible, and your ventricular septal defect is the most common. Well, what is a ventricular septal defect? Well, between the right and the left ventricle, there's a wall. That's called a septum. There's a hole in it. Could be one, could be many, could be large, could be small. And you can hear that if you listen. You will hear a murmur. Now, you need to understand some of these heart defects. A VSD is acyanotic. You're still getting blood all over the place. Just like the atrial septal defect, that hole between the right atrium and left atrium, there's a hole between there, but it still get oxygen, still going to the lungs, still come back to the body. It just means some of the blood's going to get re-put back up to the lungs because it's going back over into that right side. Now, one of the things is about shunting. If you have something that's pushing a lot of pressure, usually it's going to push away from there to where there's least pressure. Well, think about the right side of the heart. This is where the blood comes back from going around the whole body and it just gets to the right atrium, right? It's like the last part of the leg. So the pressure is really low in the right atrium and right ventricle, and then it goes up into the lungs. That left ventricle and left atrium, there are 4 pulmonary veins, okay? Flowing blood back into that left atrium. And that left ventricle, this is your engine for your heart, pumping a lot. So if I had to ask you, which way does blood flow in the heart? If there's a hole in one of the septums, it's going to go from the left side to the right side. And that's shunting. It's that path of least resistance. This side has a lot of pressure moving on. This side has none or minimal. Now, these are the classifications. And let me tell you the ones that you really need to understand. Now, acyanotic, we just talked about those septal defects and the increased pulmonary blood flow, didn't we? Because the blood came from the left side, already oxygenated, went back to the right side again before it went to the body. So we are increasing pulmonary blood flow. We're just putting it back through the lungs again. It's okay, doesn't do anything wrong. It's there. Another thing is, have you heard of a patent ductus arteriosus? This is fetal circulation. Very important concept, okay? Very important concept. This is a little tube that connects the pulmonary artery to the aorta. So if case all else fails, we can get blood from the lungs with oxygen to go to the body. And there's many times we need to do that. Now, after birth, it usually closes. There's this thing, these hormones called prostaglandins that mommy produces that keeps that little tube open, that patent ductus arteriosus, or that PDA, during pregnancy. Well, after the baby comes out, mommy's gone. So there's no more of that hormone prostaglandins there. So there are diseases we have to keep it open. Guess what the name of the medicine in a slow, continuous IV drip is given to this baby to keep it open? Prostaglandins. It's a synthetically made prostaglandin to mimic what mommy produces. So we keep that oxygen going from the lungs to the body, and we need that sometimes, okay? What happens if that duct is open and for whatever reason doesn't want to close? You're putting more flow that continues to wash through the lungs on a normal heart, right? So what do? Well, we can close it with medicines or with surgery. And the medicine we use is actually an NSAID, and it's called indomethacin. This is part of your matching list handout that I gave you. Concepts you need to know. So prostaglandins keep it open, and indomethacin blocks whatever prostaglandins are in there and it closes it. Make sense? So open or close, what do you want? We know that there can be obstruction. I've already talked about a coarctation of the aorta. Valves can be tight, and those are called stenosis and osis, okay? When there is a non-existent valve, it's called an atresia. Of all of the common atresias, it is tricuspid atresia. Well, where is that? Between the right atrium and right ventricle, there's no opening. How is blood going to go to the lungs? We're going to keep PDA open, aren't we? We're going to have oxygen until we can fix it. The other thing that can happen with decreased blood flow is called tetralogy of Fallot. This is the diagnosis that Hesse and Klex loves to pick on. The tetralogy of Fallot is all right-sided things. And what happens is, ever hear of a tet spell, a blue baby, a blue spell? Well, this is tetralogy of Fallot. And we know blood goes from the right ventricle up into the lungs and has to go through a tube called the pulmonary artery. And it goes through that pulmonary valve. Sometimes that valve, sometimes a piece of tissue flaps over it and covers it. So no blood can go to the lungs. How would you know that happens? Well, 4 o'clock in the morning, I'll never forget him. His name was Nolan. And I was just changing his diaper and turning him and washing his little face. Not much more than that, because he was a very, very sick little child with tetralogy of Fallot. His O2 sats went from 100% to 10 in about 30 seconds. He turned from a beautiful pink to a ashen bluish gray. What did I do? What's the treatment? Emergency treatment is taking the knees and immediately pushing them up to the chest. And what happens is this: there is a chest compartment and an abdominal compartment. Forcing that abdominal compartment up into the chest changes pressure, and it pops that piece of tissue off and allows blood flow to go in there. And that's usually what will take care of it. What's pretty neat is there are some older children that have unrepaired tetralogy of Fallot. And these children, they can feel it coming on, and they'll be walking, and all of a sudden they're going to squat down on their knees, on their knees onto their ankles, like sitting up, squatting. And again, it does the same thing, doesn't it? It's a knee chest. And that's how they take care of it. And we'll keep going over this. I've got some Kahoot questions for you to try to help you. And then mixed blood flow. Well, I did talk about there are times where vessels are mixed up and in the wrong place. There's one thing called transposition of great arteries. Off the right ventricle should be the pulmonary artery. Well, in transposition, it's the aorta. So unoxygenated blood's going back to the body. There's no oxygen there, right? And then where does the pulmonary artery go? It goes off the left ventricle. It goes, to the body. There's no mixing of blood here. So in this case, your patent ductus arteriosus is a real lifeline. And these children actually, on this continuous slow infusion of prostaglandins, can wait a week before surgery and get stronger and actually, eat PO, a bottle or even breast if they can. And then the other one is called a hypoplastic left heart. Of all the conditions, hypoplastic left heart is the most severe. The left ventricle muscle, the engine of the heart, is non-existent. So blood doesn't flow around. So we do a bunch of things to try to make that blood flow. First of all, we're going to make a little tube that mimics that PDA called a BT shunt. And then we do another surgery and another surgery to try, to get that blood flowing. These are some slides. I have them here. I leave them for you to look at, but I've really explained them to you, okay? Congestive heart failure. Well, we know that. We see it in adults. We know it's because the heart's not working well. The heart muscle's damaged, right? Well, sometimes it could be due to something like, how about that coarctation? It kinks. Blood can't go down to the body. Yeah, some of it goes up to the upper extremities, but some of it spills back into the left ventricle, left atrium, and back in the lungs and fills fluid up, and they're congestive heart failure. What would be a really early sign that this was going on if we didn't know? Well, you're not getting blood flowing well down, and the first little artery off the aorta goes to the kidneys. So what if you saw a decrease in urinary output? Got to go somewhere, right? It's going in the heart, going into the lungs. That can cause congestive heart failure too. So how do we treat congestive heart failure? Well, number one, we're going to hear this child, with maybe grunting, maybe nasal flaring, super clavicular or intercostal retractions, abdominal breathing, and you can hear these noisy stuff going on. Sometimes you can hear that. I mean, of course, a chest x-ray is going to show you fluid is everywhere. But what is our job? You have a child that's full of fluid. So we need to get rid of that fluid. We are going to give some diuretic. Furosemide is a perfect one, just like we give adults. Digoxin, just like we give adults, we're going to give it mics per kilo. We're not going to give just one pill or something. We're going to do it mics per kilogram per minute. How do we know that this fluid is disappearing? Intake, output, daily weights, right? We're also going to be able to see it because their oxygen saturations will get better, because now the lungs, the fluid's coming out, there's more surface area in the lungs, and they're going to be able to hold those saturations a lot better. During this time, again, we're going to place this child on some sort of oxygen. We mentioned that oxyhood is a great thing for these children because it doesn't get in their way. But again, oxygen, what does it do? It relieves hypoxia, right? And then, of course, decreases that restlessness, et cetera, et cetera. So again, we're going to improve that cardiac function, probably give some digoxin. We're going to give some furosemide. We are going to decrease whatever they're doing to breathing. I mean, usually we will not feed these children in the acute stages of congestive failure. Children can be fed with little OGTs, which is an oral gastric tube, which is very comfortable on these children. We can feed them that way, or maybe just TPN, to start out with. So we have to maintain nutrition, because nutrition, right? We don't want to delay that child. And we want that parent to understand what happened, because this is a condition, could it happen again? Well, we don't know. So we want to make sure the parents understand respiratory distress signs and symptoms to look for, and what is that child, what are we going to see with it, and what do we need to do? Hypoxemia is something that happens in your congenital cyanotic disease, a heart disease, like that hypoplastic left heart. That is a cyanotic disease. Will always have oxygen saturations under 100%. I mean, if we get it up to 92 after 3 surgeries, we're happy. But what's something that happens with cardiac children, you don't see it in others? It is because of hypoxemia, the body says, don't have enough oxygen here. So let me make some more red blood cells. Those red blood cells carry oxygen, right? But what happens is there's no oxygen to put there, but you have all these red blood cells. That's called polycythemia. You might have on a cardiac child a hemoglobin hematocrit of 18 and 54. It's not uncommon. That blood is so thick and dark and burgundy colored. It is so full of red blood cells, okay? And then, of course, with hypoxemia, chronic, you see this child here. You can see the clubbing of the fingers as they get older. Now, I want to tell you that cardiac parents are usually some of the best parents there are. We need to teach them. We need to educate them. They need to know what to look for. They need to know what to be expecting, get them ready for cardiac caths, for surgery. And then, of course, we're getting them ready to go home, how to measure medicines, have them helping you with the care so that when they get this child home, they're comfortable. Another thing that can happen, just like adults, bacterial endocarditis, and it's strep, staph, it could be a fungus. These is something that we're going to be giving prophylactics for. dental care, maybe they're going for a cardiac cath, something, we're going to always pre-medicate them with a prophylactic antibiotic. Now, rheumatic fever. No, we think strep throat is really not anything, right? Well, if we don't treat strep throat, finish the antibiotic, go back, get it checked by the physician to make sure that strep is gone, it can attack the body. And it can affect the joints, the skin, the brain, the heart. And in the heart, it affects the mitral valve and causes permanent damage. It is caused by a strep infection. So how do we treat this child? Well, if we see a sore throat and we see these signs and symptoms, and another thing they have is what we call chorea, that shuffling gait. Usually when they start stumbling and falling, parents are like, something's going on here. And they bring them in and we ask for a history of throat infections, and we're going to see it. And there's called an anti-strepolytic assay that we can take. An ASO titer is the little initials. And we're going to see strep in the blood. And we need to treat it with what? Well, it's strep, long-term antibiotics. And everything, including that chorea, that neurological weird gait, those joints, the skin. Only thing that cannot be corrected is a valve if it's already damaged. So these children will be on long-term antibiotics. Could be a month, could be 2 months, depending on the child. Excuse me. High cholesterol. You don't think of kids with it, do you? Years ago, we didn't even measure it. Honestly, we didn't know, but we're realizing today, and we're going to treat it just like we treat adults. How do we treat adults? Well, low-fat diet. We're going to do dietary changes first, see if that works. If that doesn't work, we'll be putting them on a medicine. But again, milligrams per kilogram is what we need to do, okay? Because the same risk factors for adults, heart attacks and, coronary artery blockages, et cetera, hypertension, all of that can happen. So we are monitoring it a lot earlier than ever. Cardiac dysrhythmias can be from slow to fast, even atrial fibrillation in children. You think, well, that's only in adults. Well, no, it's not. I've actually seen young children with bradycardia, less than 2 years old with a heart rate of 70. And we know that 70 is really not fast enough in order to get the blood around to all the organs in the brain the way it needs to. How do we treat it? Well, I've seen 2-year-olds with pacemakers. But remember, pacemakers on young children, the way they grow, have to be monitored closely because the pacer wires inside will need to be changed, okay? I've already talked about that tachydysrhythmia. We first initially will try medicines to slow it down, but in the end, to just absolutely stop it from happening, they're going to do one of those cardiac caths, an interventional electrophysiology study, and we're going to zap that, saying, you stop doing that. That's enough. Let the SA node do their job. Another thing is because sometimes we have a lot of flow going into the lungs, and the lungs are very protective. And the lungs say, wait, there's just too much flow coming up in here, and they get tight and they tense up because they're trying to protect themselves. And it causes that thickened arterioles, and it causes what we call pulmonary artery hypertension. Because it's tightened, you're not going to get the oxygen that you need. You're going to get short of breath and the minimal exertion. You could have chest pain, and of course, no oxygen, you're dizzy. And actually, the first treatment that we give is oxygen. Oxygen dilates the lungs. It is a bronchial dilatator. So that's the first thing, a little oxygen. And then you know what else started when I started into the cardiac ICU? Viagra. It dilates the bronchioles, and they're using that on small children, and it does work. I mentioned cardiomyopathy, and I told you most of the time it is an infection, and it's usually viral. Sometimes it could be your body attacking it, your lupus, your metabolic things. or there could be something missing in the body, or the collagen disease can cause it. So with cardiomyopathy, we try to have that heart work the best it can, but it comes to a point where they're going to need a transplant. Now, in transplants, the first in 6 months, the worst thing that can happen is rejection. So we will be placed on long-term immunosuppressive therapy. These children need to keep their body from attacking that heart, okay? And then blood pressures. Again, just like, cholesterol, we didn't check children under the age of 2, their blood pressures. We just did vital signs without blood pressures. Well, we've learned that we know that some of these children can. And we know that if we allow blood pressure to go untreated, it can kill kidneys, right? It can do a lot of different things to that body. So we are checking it, and we are placing these children on medications. And again, it is done milligrams per kilogram with close monitoring of it. Kawasaki disease is a vascularitis. It's some sort of viral something. Now, what do I mean by vascularitis? The vessels in the body become very inflamed, and it shoots off like little microemboli from the swelling and this inflammation. And our biggest concern is the coronary arteries, their vessels. And sometimes they get an aneurysm in it. What happens with aneurysms if we don't know about them? They go untreated. They burst and the child would die, right? So what do we see with Kawasaki? The first time I saw it, it was the cardiac ICU, the boss of cardiac ICU, the head of it. A 3-year-old son was brought in, and of course they gave it to me because they do those things to me all the time. And what did I see? Well, this child had had a fever, a little sort of upper respiratory, non-specific, had a rash. Then all of a sudden you saw the hands and the soles of the feet like peeling or blistering. Then you see a strawberry tongue, cracked lips. And do you see those pink eyes? I'm talking glow in the dark pink. That's the one thing I'll always remember about this little boy, those pink, pink, pink eyes. So how do we treat this? Well, the first thing we do is these children get placed on intravenous immunoglobulins for about 1 month. This is the only time we place children on aspirin. It decreases the, it causes the blood to thin, so it prevents clots. Remember, all these little microemboli could come out because of this inflammation of the vessels. So it decreases blood clots, and it's an anti-inflammatory, decreasing the inflammation, aspirin is, and the IVIG for about a month. And when these children come in and we start this treatment, as soon as possible, we're going to do an echocardiogram. We want to see what those coronary arteries look like. And they will be followed up maybe, a month later to look at it. Once they have Kawasaki, they usually never have it again. But it is something that does hit, and it's usually younger children. You see, less than 5 years old. Again, there's all the pretty little pictures, what they could look like. Again, it's IVIG, and then it's high dose aspirin, and it's about a month-long treatment. Shock. Shock with children, shock with adults, there's no difference. I think in children, your biggest cause of shock is infection, septic shock. They get an infection, we don't see the tiny little symptoms, and they can go into shock. What do you see with shock? Well, blood pressure falls, so low blood pressure. Then the heart says, oh, let me make up for that blood pressure, let me have the heart rate beat a lot higher. You're also going to see decreased peripheral perfusion, so capillary refill is going to be so prolonged. Urinary output's going to be diminished or stop. and they can get confused because of lack of oxygen. These are all things you could see with shock. Adult children, it don't matter whether it's compensated, uncompensated, anaphylactic, septic, shock. You have to treat it, and you treat it with vasopressors, fluids, whatever you need to maintain the body with the normal vital signs for that child. So here we go. Tell me about the PDA, what you remember. Surgical closure of that patent ductus arteriosus would do what? Well, where does the PDA connect? It connects the aorta to the pulmonary artery. So if that tube isn't there, and we know pressure off the left ventricle is pretty high, right? So it would shoot it back up to the lungs. So it would prevent return of oxygenated blood to the lungs. So it's something you got to look at, something you go back and read about. And I know it's a lot of information. Did I lose all of you? Okay. Let's do our cahoots. Who wants to win? Kelly, you ready to win today? Victoria, you gonna win today? There you go. Mindy? Yeah. Oops. Try that again. We might run a couple of minutes over. If you have to leave, I understand, but I made sure you got all the information you need here and in the cahoots for you to be able to do your quiz and do really well. All right, let's get going. Respiratory and cardiac systems. A majority of upper respiratory infections are caused by sorry, my blind people are here. So we know upper respiratories are mostly viruses, right? There are some of those bacteria, but mostly viruses. You walk into a 6-year-old child's room and you find them not breathing and does not wake up. What are you going to do? So immediately when you see an unsupervised child unconscious, number one, start chest compressions. You know, as I said, it used to be airway first, but no more. And I like that. Multi-select. What are some signs and symptoms that smaller children may exhibit that have a respiratory infection? You know, it doesn't even matter if it's respiratory. When they don't feel good, what are you going to see? Probably a low-grade fever. They could vomit, maybe once, maybe more. When they stop eating even their favorite food, something's going on. And sometimes they do complain of their tummy hurting. A multi-select. What do you look for when assessing respiratory function? Another thing, children, you can just sit there and watch them and you can see what's going on. How fast are they breathing? How deep is it? Is it shallow? And if it's labor, do they have retractions? Infants, are they grunting? You're in trouble. Nasal flaring. Are they breathing easy? You can see it so easily in children. Lift their shirt up. What would you look for after a child has a tonsillectomy? And these are things that we're going to be teaching our parents post-operatively, because most of these kids go home. They're not staying in a hospital. And the big thing is, if they're starting to swallow, guess what's happening? They're bleeding. And I've actually seen a hemorrhage come 7 days post-tonsillectomy. So they should be resting for at least 2 weeks after they have these tonsillectomies. This child literally had so much vomiting, blood coming up. I had to pour in a 6-year-old a whole liter of fluid. She was going into shock. That's how much blood. A multi-select. Nursing care for a child status post-tonsillectomy include. So we need to keep that pain under control, and usually it's Tylenol, and they do really well on just Tylenol. Anything in their diet should be soft. Absolutely no orange juice. That citrus is going to burn their throat, okay? And no red fluids, no red jellos, no red ice pops. It looks like blood. And then ice bag, but most younger kids don't like that, but it does work well. A multi-select. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night? So you're going to think it's maybe bronchitis or croup, tracheobronchitis, okay? That bronchitis thing is that dry cough. And this is the one that we're going to give a cough suppressant to. Usually it's not a fever, it's just a cough that's horrible. Asthma's not at night, it's all the time. And pneumonia, it's not dry, it's loose. There's junk in that lungs that need to come up, okay? Another multi-select. What signs and symptoms would you see in a child with otitis media? Pain, always pain. In fact, that's your priority care, pain medicine when you see a kid like that. You can have purulent, like just all of this gooey, serosanguinous looking stuff, and it can smell coming out of the ear. Kid who has ear pain, they're not going to want to eat, and they don't always have a fever. Not all ear infections have fever, have your fever, okay? So not always that. The monthly immunization for RSV is. And it's called Synagist. Very good. All of the following are signs of early respiratory distress in children, except we can have nasal flaring, retractions, abdominal breathing. We can have tachypnea. But if we're starting to see a child who's already has been tachycardic, now they're going bradycardic, this child's about to crash and burn on you. So if you have a child respiratory distress that's bradycardic, be prepared. That child's going to need some supplementary support for breathing. A 4-year-old child has been taking meds for asthma, but they're still wheezing. What information is important to gather from this parent? You know, been taking their puffer. What's going on? They're still breathing, still wheezing. Why? Because did they get the medicine? Did they puffed it? Did they inhale it correctly? Most children can't. So having that spacer there, make sure that they're getting the proper dose. An 8-month-old with croup exhibits what signs and symptoms of respiratory distress? So respiratory distress, you see retractions, and what's restlessness? That's hypoxemia, right? When you become hypoxic, they are going to become restless. Adults, children, they both will get that way. Signs and symptoms of asthma include all except so you are going to have, they do cough because remember, there's an inflammation, swelling, and it causes them to cough, okay? They're going to be short of breath because they're not getting oxygen. They're going to be wheezing. But usually asthmatics can get air in, but they can't get it out. So they push that expiratory phase. And usually that phase, they push it out. At the end, you hear a little bit of wheeze in the end when they get that bad. So it's prolonged expiratory phase. They get it in, but they can't pull it out. Signs and symptoms of congenital heart disease include all except remember, congenital heart disease means the heart was not formed correctly. It's not pumping the way it should for whatever reason. They're not going to be gaining weight right. Why? Because if they're congenital heart defect, that means they're not going to be oxygenating the way they should. They're going to tire easy. Tiring easy, they're not going to eat all the amount of food they should. So usually congenital heart children have a lower weight gain than, quote, children without a congenital heart problem, okay? Because they're not eating as good as they should because they're tired. Their heart's taking all their energy. What should you not do to children diagnosed with croup and epiglottitis? Well, croup and epiglottitis are swelling in the back of the throat, right? Whether it's the area in the oral pharynx or the epiglottis. You don't want to do anything that creates more swelling. So you're not going to look in there, okay? That's one thing you don't do with these children. The epiglottis is the what? So it is that leaf-like piece of cartilage that covers the larynx when you swallow to prevent choking. Yes. And in epiglottitis, it covers that larynx and you can't breathe. What do you see? Drooling, muffled voice, inability to breathe, tripod, bending over position. An emergency. Treatment for infectious mononucleosis include what? Mono, the kissing disease. It's not a big deal, right? No contact sports. Remember that kid on the trike out in the Everglades who fell and busted his spleen? It's like a big balloon that popped. No contact sports. They need to be, protecting that for the first couple of weeks until cleared by pediatrician. Multi-select. When doing an admission on an infant with a low-grade fever and a loose cough, what information is important? When you're admitting these children, it's on admission, you need to know where to put them. Do you have semi-private rooms or private rooms? It makes a difference. We have to protect this child and other children. And I want to know immunization status. That's number one. I want to know for room placement. But as a nurse, what I want to know is how high has the fever's been and when did you give the last medications so I can continue that, okay? Apgar births doesn't really make a difference at this time. Those other ones is what you need. What is cystic fibrosis? Now you get cystic fibrosis, you have a case study coming up on that, which is going to give you some more insight into it. I hit it a little bit here with some really good information for you. So cystic fibrosis is an autoimmune disease where the small intestines gets filled with mucus and so does the lungs. And in the lungs, it's like thick sludge. So we need to do good pulmonary care. And in the small intestines, it has to do with diet and giving them the proper enzymes to be able to digest food. And that's the pancreatic enzymes. So giving these medications and getting good pulmonary care, it is a full-time job with a child with cystic fibrosis. What is the greatest risk for an infant having a cardiac catheterization? The biggest risk is the hemorrhage from that entry site. Remember, femoral artery, femoral vein, it's a huge catheter comparative to these children. So what do? If it's bleeding, we put 2 fingers and push right above the site so we can look at the entry sites and making sure they're stopping breathing. And we hold it till it stops, period. How is cystic fibrosis identified? And we can identify this at birth. One of the things that we can know if we didn't have any idea is a child with cystic fibrosis would be constipated. And usually newborns usually stool within the first, minutes, hours after birth. So that's one of the ways that it's suspected. But if we don't know, or we see these things, or we know the parents, maybe there's some familiarity with it, we're going to do something called a sweat test. If you have a child with cystic fibrosis and you tell the mother to lick this child, she's going to taste salt in their sweat. So it's a sweat test. It's looking for that salt, believe it or not. These children need good salt in their diet, okay? There is no low salt diet for them. And that's all they do, just the sweat test. A multi-select. What is included in the plan of care for a child with cystic fibrosis? And I've told you it's lungs, I've told you it's small intestines, has to do with absorption of food into the body. And they do lose, vitamins with this. So taking care of the lungs, aggressive physical therapy, pancreatic enzymes immediately before they eat, and also high protein diet because they're losing other sorts of nutrients. And again, they need sodium, so they will be getting a proper amount of sodium in their diet. It's not low. What is a drug of choice for pharmacologic closure of a PDA? Patent ductus arteriosus connects the pulmonary artery to the aorta. This allows oxygen in some cases where oxygen can't get to the body. Prostaglandins keeps it open because it's kept open through mommy's hormone prostaglandins in birth, in intrautero when she's pregnant. After birth, there is none, but sometimes it keeps open. So we use an NSAID called indomethacin, and this is the pharmacological closure. Now, if we try it 3 times, it doesn't work, they can do a surgical procedure, and they actually just take a staple and they clamp it. What is not a feature of tetralogy of Fallot? Remember, tetralogy of Fallot is the most common cyanotic congenital heart defect. It's all on the right side of the heart. Excuse me. So aortic stenosis is the left side, right? So it's not that one. It has to do, there's a hole between the ventricles. There is the pulmonary artery has something on with it where blood can't get up there. And because at that time where that blood can't go up, it stretches the right ventricle. That's what we call hypertrophy. And the 4 stages where the aorta sort of pulls over a little bit onto the right side because of this VSD that's there. So tetralogy is all right-sided and it is cyanotic. What medication would you hold for an infant that's vomiting? Vital signs are 99, 88, 32. The only sign that you may see with an infant is the heart rate and vomiting. And if you see that on a child who's on digoxin, you are going to hold it. You're going to call the physician. You're going to do a digoxin level. Again, same thing you do for adults. You're going to be checking your potassium. You're going to check dig level. You're going to check an apical pulse full minute before giving it. Same as you do with adults. Why would a child with tetralogy of Fallot not gain weight at the normal rate? Again, cyanotic heart disease. Why? So when you talk cyanotic heart disease, they're not getting oxygen. They don't have oxygen. They don't have energy. They're not going to feed well. They're going to be lower in weight. They're going to be on the lower portion of the growth scale. Absolutely normal for them. All are examples of cyanotic heart murmurs except which one? Again, this is going back and look at the list. I mean, some of these I just mentioned. I don't go into the full detail on them because you'll get totally confused. It took me many years to learn, all of these diagnoses. But when you talk about a stenosis, we know there's still an opening. That means the hole that goes from the left ventricle to the body is just narrowed, but we're still getting oxygen. It still goes through the proper channels to get there. Truncus is just, there's no valves and the whole thing is open like a trunk, but still it is a cyanotic disease. Aortic, no. What is the most common cyanotic congenital heart defect? Tetralogy of Fallot. Tetralogy of Fallot, most common cyanotic. A PDA is oxygen. We're putting oxygen around. Nursing care following a cardiac catheterization. We are going to check the insertion site for a hematoma. This child is not getting out of bed for 24 hours. We are not going to be touching that leg that had the holes in the right groin. That right leg is going to keep straight. And we are going to slowly raise the bed, but maybe not even up to 45 degrees. A multi-select. Nursing education for the cardiac catheterization include all except. You know, we're going to tell them they can't ambulate, and we're going to tell them they cannot bend their extremity. We're going to watch vital signs. We're going to monitor that dressing. Which information is most important when rheumatic fever is suspected? You're going to find two diagnoses in pediatrics that are caused because of this. This is the first one. Have you had a sore throat? Remember, strep infections causes rheumatic fever. How do we treat it? We give them the antibiotics to treat the strep, usually a month long, but all the symptoms except for that valve, if it's permanently damaged, everything else will be reversed. Signs of shock in children include all of the following except. So shock, you're going to see hypotension, not hypertension, altered mental status, poor capillary refill, tachycardia. Yes. Decreased urine output. What is the treatment for Kawasaki disease? Remember, this is an overall vascularitis, systemic vascularitis, inflammation of vessels. And we're going to treat it with aspirin to prevent clots and to decrease the swelling and the IVIG for your immune system because it is a viral type thing. Which of the following best describes the pathophysiology of Kawasaki disease? Multi-system vascularitis, which may affect the coronary arteries and cause aneurysms. Very good. Yes. A multi-select. A clinical manifestation of Kawasaki disease is So we're going to see the palms of the feet, palms of the hands, soles of the feet, like white, cracked, blistery looking. The eyes glow in the dark red, strawberry tongue, cracked lips. And you're going to see a rash, but it's not going to be that description of it. It's more of a macular type thing. Which of the following is the most common cause of shock in infants and children? And most common cause of shock in infant and children is infection, sepsis. They have no immune system. They can't handle it. What are the defects associated with tetralogy of Fallot? Remember, again, it's all right-sided. The pulmonary artery, that's number one. We know that's where the blood can't go to the lungs. The hole between the chambers, that aorta pulls over. And the ventricle on the right side gets a little bit swollen or hypertrophic because the swelling, when that's covered, it stretches it like a balloon. A young child with tetralogy of Fallot may assume which position naturally when having a tet spell? I actually was in the grocery store and I saw a child sit down like that. And I was like, Mom, why did the kid do that? I was being nosy. And she told me, and I said, you know, I thought so. It's called squatting, okay? Poof, right down like that. That's what they look like. And again, it changes the pressure between the abdomen and the chest and it pops it open. Transposition of the great arteries. What is switched? What are the great arteries in the heart? Think of it that way, right? And it's the pulmonary artery and aorta are switched. And that's the name of the surgery. Arterial switch is when we switch them open. Sometimes we even have to not only put them on that prostaglandin and keep that PDA open because that's oxygen. Sometimes we have to make a hole, a balloon septotomy, it's called, where that foramen ovale is between the right and the left atrium. And that helps, you know, with the blood flow going around and mixing it up good. These children are sick until we get them oxygenated. Which of the following is not an intervention indicated for transposition of the great arteries? So we want to keep the PDA open with the prostaglandins, that's oxygenation. The name of the surgery is called a switch. The balloon atrial septostomy is to make more blood flow, yes. No oral, nothing here. There's nothing oral that can help this child. We need intravenous stuff going on. So oral vasodilators, absolutely not indicated. Doesn't do anything. A multi-select. Why is prostaglandins given to a child with transposition of the great arteries? Remember, you have blood flowing and it's not mixing. Okay, you have oxygenated and unoxygenated. They need to mix. Why? Well, number one, it helps with oxygenation, but number two, it helps keep that cardiac output. Please, prostaglandins are not antibiotics. It has nothing to do with infections, nothing to do with endocarditis, okay? All it does, it keeps open that duct, which keeps oxygen and cardiac output going. What is the purpose of giving indomethacin to a neonate with a patent ductus arteriosus? What does indomethacin do to that PDA? Remember, we have prostaglandins and we have indomethacin. What does what? So indomethacin says, hey, prostaglandins, we don't need you no more. Go away. That duct needs to close. And that's exactly what it does instead of doing surgery. Where is the patent ductus arteriosus? Let's see if you got it now. The aorta to the pulmonary artery. Okay, make sure you know that. Very important concept. This heart defect allows blood to pass from the left ventricle to the right ventricle. That means that septum, something's going on. What is that called? It's called a ventricular septal defect. Very simple, VSD. A multi-select. What is a sign of toxicity in infants? Infants, what do you see? You're going to see nausea, vomiting, and you're going to see the heart rate. You're going to say, how nausea? They tend to retch when they're nauseous. Are they going to tell you they see yellow spots? That's adults, okay? That's the difference. They can tell you yellow spots. An infant is only that vomiting, that nausea, retching, and the heart rate. And of course, if there's a digoxin level. What is congestive heart failure? Whether it's an adult, whether it's a child, what is congestive heart failure? What it is the heart gets weak and then the fluid builds up, goes in the lung, and it fills up. How do we treat it? Digoxin, Lasix, daily weights, INO, and giving them the chance to breathe and giving, of course, giving them their proper nutrition also. Left-sided congestive heart failure causes what? So if the left side of the heart is, let's say that coarctation is kinked, and it's causing extra flow to go back into that left ventricle, what does it cause? Remember that hose kinked, it keeps going backwards and backwards. So you're going to see all the lung things, shortness of breath, coughing, fluid in the lungs, tachypnea, very good. A multi-select. Signs and symptoms of rheumatic fever include you're going to see a rash. You're going to see them with that wiggly, wobbly gait. And then, of course, you're going to see those nodules and polyarthritis. And again, once we treat rheumatic fever, which is a strep infection, we treat them with the antibiotic, everything goes away except permanent heart damage. After a heart transplant, what's the leading reason children die? And it's rejection. It is not infection, it's rejection. The body says, no, no, I can't have you. A multi-select. A child's about to have a chest tube removed. What should you do? Now I'm telling you, chest tubes removed, I've done them in the adult ICU, status post open heart surgery. And adults tell me it burns intensely when we pull them out. So knowing that, we know that we're going to tell the child that it's going to hurt a little. Okay. You got to be honest with them. You're going to take their vital signs. You're absolutely going to medicate them for pain, and of course, on their level, tell them what we're going to do. Because it literally sit them up, we put a chucks underneath, and we say, take a deep breath, and we pull, and it's going to burn. So please let them know. And then it's like really quick, within 10 seconds, it's already better. A child just had abdominal surgery, cannot cough well enough to expectorate secretions. What is your priority now? I mean, we got to get those secretions out. We're going to end up with pneumonia. Now we're going to have more problems as part of post-op care, right? Prevention of, atelectasis and emboli. We are going to medicate them for pain, number one. And once we medicate them for pain, they can be moved. They'll get out of bed. They'll do instead of spirometry. But if they're in pain, they're not going to do anything, just like an adult. An infant of 3 months has a fever of 103.6. What would you medicate the infant with? Only Tylenol, acetaminophen. They cannot have ibuprofen, Motrin until they're 6 months old. Something to do with platelet aggregate, something going on there with bleeding stuff. So only Tylenol till 6 months old. A newborn infant is assessed. The nurse finds very weak lower extremity pulses. What should she assess next? What could be going on with very weak or no lower extremity pulses? I'm thinking of possible coarctation of the aorta. Remember, that's where I'm going to see higher upper extremity blood pressures and lower extremity blood pressures. And that can help make a diagnosis for the physician and will expedite care for that child. A multi-select. A critically ill child's on complete bed rest. What can a nurse do to prevent complications? Doesn't matter, a child, an adult. There's all these things that we do in post-op care to prevent those issues of, the atelectasis of the lungs and blood clots and sores and all of these things, right? We're going to use, instead of spirometry, we're going to give pain medicine if they're hurting, keep them clean and dry, whether chucks, whether diapers. And we're going to use pillows and blankets. You take them, turn them on the side, and children will wiggle back. So you prop them up and keep them over to get that one lung moving. And of course, elevate the head of the bed. It helps the lungs breathe better. How can oxygen be delivered that is easiest tolerated and accurately monitored for infants? That oxy hood is actually the best. It's clear, they can suck their fingers, they can suck on a pacifier. A nasal cannula is a good choice, but remember, this is something blown in their nose, it tickles, is taped to their face, and they can get in it and they can rip it. So it's not as easily tolerated as oxy hood. A multi-select. What procedure are used to keep lungs open with a child with cystic fibrosis? You're talking lungs in any way. How do we take care of lungs? deep breathing, chest PT, exercise, and we're going to ambulate more than PRN. We're going to get them up twice a day, 3 times a day, not PRN. A multi-select. Children with cystic fibrosis require pancreatic enzyme with meals. What teaching should be done? You know, this is something you're going to see on your cystic fibrosis case study also. You know, it's one of those things that need to be taught, so they're going to be given it appropriately. You know, the first thing is we're going to give it right before meals, not an hour before, not 2 hours, right before. Sometimes we have to sprinkle it on the food if they can't swallow it. Children grow, so they need their doses increase as they grow. And sometimes there's this powdered stuff that's used. We just have to make sure their mouth is rinsed when they're done, because it can hurt the tooth enamel. What is a cardiac defect when there's no valve between the right atrium and left ventricle? So the right atrium, right ventricle, what's supposed to be there? Start with it there and you got your answer. Right atrium, right ventricle, what's in between there? And there's nothing there. And remember, when there's nothing there, it's called an atresia, no opening. So it is a tricuspid atresia. And last question. When an infant is breathing fast, tires easily, needs rest periods during feedings, what should you assess? What's going on? They're breathing fast, tiring easily, needs frequent rest periods. What do you need to assess? What do you think is going on here? They're probably filling up congestive heart failure, right? Breathing fast, so that means check their lungs, so it's the breath sounds. All right, let's see how we did today. Number 3, KL. Good job, Kelly. 2, Ashley. And number 1, D. Number 4, MM and Baral. Good job, guys. So what I want you to do is sign your attendance attestations. I will be sending you the answer to that handout that I gave you. It is a great way to put into those things that I've told you about. So if you know about prostaglandins and indomethacin and PDAs, and it helps you really put it all together a lot easier, okay? I know this is a rough week. You're probably gonna have to go back and listen again, but I've hit you with that key things that you need to know. Can I help anybody with anything?
Good.
Bye, guys.
Thank you for everything.
No, my pleasure always.